Started your time.
Yes. Any other page? First page, ma.
I'm starting your 10 minutes time.
Okay. Hi, I am Muthulakshmi, one of the exam candidates today. I have read the instructions and I'm ready for the structured discussion.
Okay. So after going through this scenario, what is your immediate management, doctor?
So scenarios, I am suspecting a bladder injury in the background of total abdominal hysterectomy for abnormal uterine bleeding. The previous two cesarean section, I am being assisted by ST1. So my immediate management is, so I'm suspecting a bladder injury. So first I'll stop the procedure. I'll tell the circulating nurse to inform my consultant who's nearby, and also I'll tell the anesthetist this procedure may take a long time. He may arrange extra blood needed, or he may give antibiotics if the surgery is getting prolonged. And I will inform the scrub nurse to keep the extra instruments ready. And my consultant will come assess and confirm the bladder injury. After that, my consultant inform the urologist. Uh, the next step is, so my consultant along with the urologist will do a bladder dissection, meticulous and sharp dissection with fine scissors. Uh, then
Okay.
after,
Yeah. Okay. So you had informed the consultant, and the consultant has arrived. Meanwhile, uh, how will be your approach for further surgery? How will be your approach here onward?
yeah, so after separating the bladder, so then we need to proceed hysterectomy in the usual way. So first I lift the uterus by putting two straight clamps on the both corners. If needed, we can use a ball for self-retaining retractness. Bubble packing will be done. Then first clamp will be on the round ligament. Curved clamp will be applied in the round ligament in the middle. Clamped, cut and ligated with one polyglactin. Then decision for ovaries removal retaining will be already decided before the surgery. So if ovary is removed, we'll apply clamps on the infundibulopelvic ligament, or if ovaries are retained, we'll clamp on the tubo-ovarian ligaments. Then clamp cut ligated with one polyglactin. Then if we are clamping the infundibulopelvic ligament, before that we open the two leaves of broad ligament and we'll keep the ureter under vision. Before applying every clamp, we'll make sure ureter is away, not getting injured. Then after that, here bladder is already dissected. Then curved non-crushing clamp will be applied on the uterine artery perpendicular to the uterine artery, clamped, cut and ligated with one polyglactin. The same will be repeated on the opposite side. Then straight clamps will be applied on the Meccan rods and uterosacral ligaments. Clamp cut and transfixed with 1 polyglactin. Same will be repeated on the opposite side. Then uterus with the cervix, if possible, because it is having additions, will do a total hysterectomy. Otherwise, we can do subtotal hysterectomy with the opinion of our consultant. Then once the specimen is out, we'll hand over to the cysto for proper labeling and send it for a histopathology. Then vault will be closed with continuous or intermittent suture with 1 polyglactin. Hemostasis will be checked. Then after that, bladder injury part will be done by my consultant with the urologist. So ureteric opening needs to be identified first, and size of the defect and site of the injury has to be identified. If needed, we can also put a ureteric stenting with a cystoscopic guidance, or we can also inject a indigo carmenti IV. We can check the color change in the urine. So after identifying the ureteric opening, then we can close the bladder defect in 2 layers, watertight and continuous non-locking sutures with 2,0 polyglactin, and the decision for suprapubic catheter will be decided by the urologist. Then if needed, we'll keep a intraperitoneal drain. Then after checking mobs, instruments, needles count, and hemostasis, and checking the color and the amount of the urine, then we can close the abdomen in layers. Peritoneum will be left untouched. Then rectus sheath closed in a continuous non-locking sutures with delayed absorbable or non-absorbable suture materials. Then subcutaneous tissue, if it is more than 2 centimeter, we can close it, or we can keep a drain. And skin either closed with subcuticular or interrupted sutures or a stapler sutures. Then after that, so we'll do a post-operative instructions.
So what will be, yeah, so now you have completed the surgery. How you are going to manage this patient post-operatively? And what are the
Post-operatively,
clinical governance issues?
so post-operatively, so this patient will be shifted to HTU for vitals monitoring on a Mears chart and input-output charting. IV fluids, antibiotics, analgesics will be given. The patient will be taken care by the MDT, including my consultant, intensivist, anesthetist, and also the urologist and the special nurse. Then we'll also assess the need for a blood thinners with the dose by consulting a hematologist. The detailed documentation of the procedure will be done. And then catheter, she's on suprapubic catheter, and also she'll be kept an interwelling catheter. So catheter care will be given by the catheter care nurse. So, and once the patient is stable, her hospital stay might get prolonged. Once the patient is stable, started mobilizing, eating fluids, then we can plan for her discharge. And during discharge, so we'll write a detailed care plan to her general practitioner for further follow-up. And she will be asked to review in 2 weeks with a histopathology report, and also with a review with the urologist, because she is going with a catheter. And in between, if she has any red flags like fever, any discharge, or any abdominal pain, she will review. 24 hours contact numbers will be provided to her. And so catheter care nurse, taken care by her community nurse, and the catheter should not get blocked, because blockage of the catheter will lead to opening up of the fistula. So this advice has to be given to the patient. And after 2 weeks, so she needs to repeat the cystogram and see whether the fistula has closed or not. If the fistula has closed, then we can consider removing the catheter with the help of the urologist. If not closed, then if feels again defect is there, catheter has to be kept for 1 more week with the antibiotic coverage. And regarding clinical governance issues, so duty of candor to the patient, apology to the patient, and documentation of the events, and debrief the patient, family, and also the debrief the team, and also write an incident reporting, and also inform the risk management. And since I have done the procedure, so I will do a reflective practice.
Okay. Anything else you wanted to add to any of this question? Last 2 minutes are still pending. Hello?
Yes, ma'am. Yes, ma'am. Thinking.
Hmm.
And if the cervix is not removed, we'll advise her about the pap smear, regular pap smear screening. And also, since it's a major surgery, post-operative instructions will advise not to lift a heavy weight and not to have a intercourse, and not to drive at least for 4 to 6 weeks until she feels comfortable.
Okay. So last 1 minute, I am ending it. Very well done,
Yes, ma'am.
Lakshmi. Yeah. So you had prepared a topic. Very good. Yes.
Yes.
Yeah.
Yes, I prepared
Only
for you.
yeah. Only 2 points. What I have wanted to say. Post-operative plan will not be MDT.
Okay, ma'am. Okay.
Post-operative plan will be shifting her to HDU or a post-surgical ward for
Mm.
monitoring on nuance charting where IV fluid, antibiotics, analgesics, assessing VT risk assessment and adding thromboprophylaxis accordingly will be a plan. Okay, along with catheter care. Hmm? Yes, so this can be done by ST1, ST5. She is not having any post op
Yes, ma'am.
post post
Okay.
surgical uh, uh, repaired bladder injury. Do you think you will be needing MDT?
No, ma'am. Okay. Okay, ma'am.
Yeah, so
The
that is what why.
communication with the colleagues was there, ma'am. So I
So you had
my,
already communicated in urogynecology's
yes,
model.
ma'am.
Each questions will not be having that point. Okay, each
Okay.
question will not be having that point. You had communicated adequately whenever needed. Okay, so that is not the problem. Then in referring her after 2 weeks, she will follow up with you people. She will not go to urologist.
Yes, ma'am.
Okay, or urosurgeon. Primary caregiver were you. So the patient will come to you. You are going to assess whether we can remove the catheter with the help of retrograde cystourography. If there is no further leak, you can very safely remove it. If there is any leak or chances of fistula, you can keep the catheter for one more week.
Yes, ma'am.
Yes.
Yes, ma'am.
Okay. So
Okay.
remember these two things. Okay.
Yes.
These two things are only what I had noticed. Apart
Yes.
from that, it was a perfect question, perfect answer. So a situation is a suspicion of bladder injury, high risk case which was posted for total abdominal hysterectomy with previous to LSCS BMI 30 by trainee. Okay. So
Yes.
ST5 and ST1 both are trainee. So this is an emergency situation, needs assessment, management under senior supervision. Now, what will be your immediate action? Stop further surgery or dissection, call for help. This will go simultaneously. Hmm? So you involve the theater people, you involve the scrub nurse, involve the consultant. You had given extra dose of antibiotics, arranged extra instruments, suture material, samples for groupings, cross matching. Alert the theater runner to give her blood to inform blood bank. Okay, if need arises. If your ST1 is getting anxious, you may communicate with him and calm him as of now. Here, check for the urine color and catheterization. Check. Actually, you can confirm whether the catheterization is there or not. Hmm?
Okay.
This is the immediate action. Meanwhile, I will plan my definitive management. This is what we are planning. The immediate action has been completed. Now, the planning of definitive management is identification and confirmation of site size, extent of the bladder injury. Hmm?
Okay.
Arranging necessary investigation. This you had missed out. No, you mentioned in the next question.
Ah, yes, ma'am.
Cystoscopy, IV. You mentioned. You forgot to mention about methylene blue.
I mentioned indigo carbon. Yes, ma'am. Methylene blue also we can put. Yeah, that is yes.
Yeah.
Yes.
Okay. So this 2 point involve consultant and urologist if needed. Decided regarding the further procedure whether to proceed with hysterectomy or wait and watch. Hmm? Repair injury first, or repair injury after hysterectomy. These are the two concerns. Now, what will be your approach when it comes to the further injury, rest of the surgery? So once the injury has been confirmed, the extent has been confirmed, site has been confirmed with the help of methylene blue or cystoscopy, you can inform the and assess the proximity with the ureter. Here, the consultant can decide to repair the injury by himself, or he might take a help of urologist. Meanwhile, while awaiting a help, we can go ahead with the hysteroscopy. Very nicely, you mentioned all the steps of hysteroscopy, because this was a task where you could have managed all the points. So it's okay. I'm not going to say that no, don't do this or don't do that. Since we were having a time, you had done it very nicely. Okay. Define the extent of injury and decide whether the consultant can deal with it or required input from urologist. Proceed with hysterectomy with routine steps with the help of assistant, and consultant will be here now. Okay, so that we will not injure. This sentence is very important. The my further procedure or further hysterectomy will be very safe, thinking in thinking in my mind not to injure or not to extend my bladder injury. Repair bladder injury in two layers, which will be done by consultant urologist, where follow the principles of bladder repair. You go here, you can say all the points which are important in bladder repair principles. So what are the points? Single
What
layer or double layer,
water type?
polygalactin, 0.5 centimeter away, away from each other. Okay, 0.5 centimeter away from each other, and 0.5 centimeter away from the margins. Continuous. Okay, it can be continuous. Even you can take a figure of 8 if there is a small defect. Small defect. Then watertight, leak proof. Leak proof, watertight, continuous irrigation, need SOS, need for ureteric stenting can be assessed during the procedure. So these are the principles of bladder repair. Posterior, as the injury is posterior, great care must be taken to avoid ureters, may require ureteric catheterization or stenting, to be very precise. Check that repair is effective by filling bladder with methylene blue or Hartmann solution. That is watertight, leak proof. Indwell catheter and possibly a drain, intraperitoneal, okay, which you put very nicely. Then complete the procedure. Hemostasis to be checked at each point. Label specimen. Send it for histopathology. WHO sign off. So WHO sign off is everything, including your hemostasis check, dressing and catheter care. Check the urine also. You can mention. Check the urine also. You mentioned very nicely. Shifting to now, my third question was post-operative management. So shifting to post-surgical ward or HD. I will not send this patient to HDU. Why?
She's not like very sick and all, like not lost
Yes. So
blood.
yeah. Yeah, so post-surgical unit where news charting will be completed, complete documentation, adequate hydration, IV fluids, antibiotics for 5 days, adequate analgesia, encourage mobilization, assess need for VT and VT prophylaxis according to the risk. Continue catheterization for 7 to 10 days or up to 2 weeks also you can continue. Arrange debriefing to the patient, discuss duty of candure. Discharge and follow follow details. Okay, follow up details. 24-hour contact details needs to be shared with the patient. Complete incident form. Removal of catheter. On removing catheter, check post-viral residual volume and whether there is any leaking or any complaints of the patient. Inform the GP once patient will be discharged. So all the points you had mentioned here. Did you think you have missed out on anything? No, I
No,
don't
ma'am,
think.
I
Yeah.
told.
Yeah. So regarding clinical governance, inform risk management, that is DATICS, root cause analysis. This you missed out, dear. Yes or
Yes,
not?
yes,
Yeah.
ma'am.
So if the injury is not an anticipated injury or anticipated complication, then they might think of root cause analysis. Reflective practice you mentioned, duty of candor you mentioned, Then follow up with the consultant to discuss complication and ensure no residual effect. Discuss this can be presented into the departmental meeting, or even if these are having repeated injuries, then we can discuss into the audit meeting also. So this is the last point. Now these are the very nice talk article where they had mentioned the principles of bladder repair. I thought of just underlining it. Okay, so
Yes.
1 or 2 layer 2 to 3 0 absorbable polygalactic suture placed 0.5 to 1 centimeter apart and 0.5 to 1 centimeter lateral to the cystotomy angles. Extracorporeal knotting is preferred. Interrupted suture can be used also. So continuous non-lock or
Interrupt.
extracorporeal interrupted figure of 8 is also can be used. Avoid obstructing ureter and urethra. Stenting whenever needed. Thermal injury requires adequate debridement. Mm? Uh, Continuous watertight leak proof. Continuous post-operative bladder drainage for 2 weeks. Yes. And
Yes.
whenever there will be a plan for catheter removal, subsequent
Records.
retrograde cystourography can be done. Okay. In spite of all these, the chances of ureteric fistula is there, that is 5%. So this is principle of bladder repair, which has been mentioned here. Now coming to the domain-wise scoring, very well done, huh? Very well done, Muthulakshmi. Interpretation and acknowledging the information, which is very important. No, array shit. I had here. I had not. Hmm. So here communication with patient and families is offer a debrief patients immediately after the surgery when the patient is able to understand, communicates with the patient on risk factor, management report, share the report with the patient, that is duty of candor report, invite patient, follow up and discuss the complication with consultant and ST5. Patient safety, stopping of the procedure immediately, calling for help, follow the principles of repair of bladder injury, WHO safety checklist, HPR labeling and specimen, post-operative care of catheter and antibiotics, asserting allergy and safe prescription, understanding your limits, when to involve senior, when to involve other specialties and clinical governance. Thorough knowledge or understanding about the injuries or literature on managing bladder injuries during surgery. Complete, and you have to identify it's a complication of gynecological surgery. Identify also this is a high risk patient. Communication with colleague, even your ST1, here ST1 will be communicated. Allay anxiety. Okay, so he might be anxious at that time. So allay anxiety at that time. Able to communicate with the colleague in theater, anesthesis, nursing team, others, runner, etc. Involve consultant when suspects complication. Involve urologist in communication with GP on the complication and treatment. Continence nurse specialist. So you mentioned all the points. Okay, see this ST1 only was missed out. So this information gathering is not needed here. So overall, this was a very good task which was done by you, and really happy the way you had presented this task today, dear. Any question?
No.
So